A very good afternoon to you all. On behalf of BLK Center for Child Health and the IAP Central Delhi City Branch, I, Dr. Swati, welcome you all to this Telepeds webinar. Today we will be discussing about immunization in adults and elderly. As pediatricians, we are very familiar with immunization in childhood, but immunization simply does not stop at 18 years of age. It is a lifelong preventive strategy because with growing age and adults and elderly often have a lot of comorbidities, which makes them vulnerable to vaccine preventable diseases. So today this session will help us understand what are the vaccines available for this particular population. So to chair this session, I welcome Dr. Anil Bardani. Sir is Principal Director, Internal Medicine, BLK Max Super Specialty Hospital. Welcome, sir.
Thank you. Thank you.
I also welcome Dr. B.B. Agarwal. Sir is Senior Director, Department of Pediatrics, BLK Center for Child Health. Welcome, sir.
Thank you, Dr. Swati.
So I warmly welcome our speaker for today, Dr. Amit Tyagi, Principal Consultant, Department of Pediatrics, BLK Center for Child Health. And over to you, Dr. Amit.
Yes. Thank you, Dr. Swati. So today we are going to discuss about a topic which often gets overlooked in healthcare, which is adult immunization. So India has greatest immunization coverage in children through universal immunization program, and because of this coverage to children, we are observing that there is a epidemiological shift or vaccine preventable diseases from childhood to adolescent and adult age. And at the same time, there is a lifestyle disease increasing. The people are traveling internationally, there are occupational exposure, and our population is also aging. So that's why the adults are at higher risk of developing these vaccine preventable diseases like flu, pneumococcal, Shingrix, like herpes zoster. So now we will discuss these vaccines in adult, and after giving these vaccines to our adult population, so there will be huge impact on reducing the burden of illnesses, especially the vaccine preventable diseases. This will also improve the herd immunity, it will reduce the transmission of the diseases, and will also prevent outbreaks. And one important thing is that these vaccines will increase life expectancy and also the economic productivity. So before we go to other vaccines, so we should have a look on overall vaccination status in the India. So the overall vaccination coverage is around less than 2%. If we take 100 people, adult persons, and we check their vaccination status, then we found only 2 will be vaccinated. So this was a study.
The slides are not moving.
I have already moved the slide.
No.
Okay.
Yes, now.
Yes, slide is not moving. Yes.
Now it's started.
Now it is.
Okay. Now, can you see it? Okay.
Now it is moving.
Okay. So this is the overall status in India, that less than 2% adults are covered with the vaccines. This study was done in 2019 in AIIMS Jodhpur, which shows that 1,400 individuals were vaccinated in an adult vaccination center. So this was a vaccination center, especially for vaccination to adults. And this data provide that mostly 60% adults got post-exposure vaccination. And the rest of 23% were only getting pre-exposure vaccine, that is hepatitis B, pneumococcal, typhoid, influenza, meningococcal. So this constituted only 23%, which is quite higher, but this was because of a center-based study. So probably the percentage was higher. So pneumococcal vaccine was only 7%, hepatitis B 8%, and influenza was 1%. So if we look at what are the different vaccines which we can give pre-exposure or post-exposure. in adults. So we categorize 4 groups of vaccines in this presentation. One is that first, according to their age requirement, means people, adults requiring routine vaccination as per their age, maybe more than 50 year or 18 to 50 year of age. Then second group will be the adults who are at high risk or having some diseases, chronic diseases, or adults who are lacking some immunity. So that group who will require these vaccines. The third group of vaccine is for travelers, persons who are traveling internationally or in India, or they are plan to travel to some area who that area, particular area have that particular disease. So like typhoid, cholera, Japanese encephalitis, meningococcal. So these are the vaccine which we give in travel risk. The fourth one, these are vaccines which are yet not available in India, or some are approved in India, like dengue vaccine has been approved, but it is still not available. So we will cover only these vaccines which are available now presently in India and approved for vaccination. You already know there are different type of vaccines. So just to brush up your knowledge about the vaccines, if you categorize the vaccine broadly, it is live attenuated vaccine or non-live, or it is inactivated vaccines. So there are different type of vaccines according to their manufacturing. The live attenuated vaccines, live vaccine which contain the live virus, which has the capacity to multiply. So live vaccines like chickenpox, MMR. The inactivated or killed vaccines are hepatitis A, influenza, polio, and cholera. And there are some other vaccines which also come in category of non-live vaccine, like subunit recombinant vaccines and toxide vaccine. Toxide vaccine where the toxin is weakened in the laboratory and then it is taken as a vaccine, like diphtheria and tetanus, which provide protection. And the next generation vaccines are like mRNA, plasmid DNA vaccine. So this synthetic mRNA vaccine, like COVID vaccine, and this is the plasmid DNA vaccine, which is the next generation vaccine. So where when you inject this plasmid DNA vaccine into the person, the cells take up these vaccine and they manufacture biological factory inside the cell, and then they produce the antigen, particular antigen to produce immunity. So different types of vaccine, but broadly, if you take the live vaccines and non-live vaccine, because we have to take in consideration while we are giving the vaccine that the person getting the vaccine is getting live vaccine or killed vaccine. Because if you give the live vaccine to an immunocompromised person, so there will be some problem in that giving that vaccine. So you have to take in consideration, you have to first check the vaccine is live or it is inactivated. Now we can also categorize the vaccine on their priority of need. Like some vaccines are vital, means they cover those diseases which has high morbidity and mortality. And they emphasize the universal coverage, so they provide the herd immunity, like DPT vaccine is a vital vaccine. So these vital vaccine we provide to each and every individual in the community according to the age. The second group of vaccine is essential vaccines, means they cover those vaccine, those diseases which has moderate to high burden of diseases, and they are target vaccination strategies to prevent the diseases. The desirable vaccines are those vaccines which provide additional health benefits. They are not vital or essential, but it is based on individual risk assessment and cost effectiveness. So category wise, vital, essential, and desirable. Based on these category, we will see our further slides, different types of vaccine, and then we will decide which vaccine we have to give to different patients. So this is a slide that seems a busy slide, but just to make it simplified, that these are the list of vaccine. These are 9, 11 to 12 vaccine on the left side, first column. And in the first row, you can see there are different groups. There are 9 to 10 groups of patients who are high-risk patient or at-risk patient, like patient with diabetes, patient having chronic liver disease, alcoholism, cardiac having cardiac or lung problem, patient of chronic kidney disease, patient with asplenia, complement deficiency, sickle cell disease, patient with malignancies, and in the last row you can see the patient who are immunocompromised or having HIV positive status. So these are the groups, and on this side these are the vaccines. So you can see first in yellow color, the first DPT, hepatitis B, MMR, chickenpox, HV. These are all vital vaccines in these patients. Suppose we take first example of diabetic patient. So a patient should be offered these five vaccines like DPT, hepatitis. If they are not vaccinated or they have not received vaccine in their childhood or they're not vaccinated, then these vaccines should be offered first. Similarly, in diabetic patient, the shingles, that is herpes, the Shingrix vaccine for shingles, pneumococcal vaccine, COVID-19, if there is epidemic or local epidemic, you can offer Hib vaccine. So these are come in essential category. And the influenza and meningococcal, these are vaccine which are desirable in patient with diabetes. So similarly, you can see for the different groups that these vaccines are almost the same pattern. DPT, hepatitis are all vital in all these groups. But this MMR or chickenpox vaccine are contraindicated in patient with who are immunocompromised or are HIV positive, where their CD4 cell count is less than 200. So these vaccines, then these are two vaccines, MMR, chickenpox are live vaccines. So they should be avoided in immunocompromised patient or HIV positive patient where the CD4 cell count is less than 200 uh, uh, unit per liter. Similarly, this is the column with pregnancy. If the patient is pregnant, so there are four vaccine which she should be offered. One is DPT, it's a vital vaccine. It should be offered in each pregnancy. Hepatitis B vaccine, if the earlier hepatitis B status is not known or the patient is not immunized, then you should offer the hepatitis B. If there is a COVID epidemic, you can also offer this COVID-19 vaccine and influenza, which is desirable. So these four vaccines or three vaccines in pregnancy can be given. Similarly, in malignancy or cancer, we can offer these vaccines. And the last group is group of travelers. The travelers who are traveling to India or person who is traveling from India to other country. So person should have all routine vaccination, and depending upon where the person is traveling or going destination. So the each vaccination you can prioritize according to their need. So now we start with ourselves. That these are the vaccines which a healthcare personnel, doctor, lab worker, or any nursing staff should get. So these are the vaccine list. As I earlier told, these DPT, hepatitis B, MMR, chickenpox are the vital vaccine. They should be offered if the patient or the person is not immunized early. So the DPT should be given every 10-year dose. Hepatitis B, if not vaccinated, 3 doses, and the person should get a booster dose every 5 years. Similarly, if the person is not immunized with MMR or chickenpox, they should be offered 2 doses of each these live vaccines. Similarly, if the person is working in an endemic setup, the booster dose should be given every 3 years. COVID vaccine should be annually, and the pneumococcal vaccine should be provided if the healthcare personnel is having some additional risk or having some diseases, chronic disease. They should be offered pneumococcal vaccine also, and definitely the influenza vaccine should be offered annually to any healthcare person who are working in hospital or any clinic setting. Now we will take, there are around 15 vaccines. So we'll go one by one these vaccines. We'll be discussing briefly and to the point what are the different type of vaccine, what are their indications, what are their indication in high risk group. So the first vaccine we'll be taking is influenza vaccine. The influenza vaccine comes two types, that is inactivated vaccine and the live attenuated vaccine. So we currently are using this inactivated vaccine. Most of the patient live vaccine, we initially it was available, but now we don't use the live attenuated influenza vaccine. And currently the trivalent vaccines are also available because the fourth strain, Yamagata strain, is out of circulation since 2020. So if there are only trivalent vaccine, you can provide these. They are not expensive, and you can provide to your patients the trivalent. If quadrivalent is also available, you can also provide it. But the strain has been taken out because it's not prevalent. So what are the indication or recommendation? It should be given to person who is 50 year of age and during pregnancy. So one dose, more than 50 year of age, they should be adult should be offered one dose yearly. It can be administered with other pneumococcal vaccine or shingle vaccine. The contraindication of this vaccine, flu vaccine, is basically if the person was allergic to this vaccine or vaccine component, had severe allergy, anaphylaxis, then it is contraindicated. But it is not, egg allergy is not a contraindication for influenza vaccine because there is a very minimal amount, less than 1 microgram of the ovoalbumin in the vaccine, which is prepared on the embryonic embryo. So there is a very minuscule amount of ovoalbumin in the vaccine dose, but they usually don't cause any severe reaction. Another precaution should be taken in GBS. So if any person who had GB syndrome in the last dose, within 6 weeks of getting the last dose, precaution should be taken to give this vaccine. So this is the recommendation age group wise, like more than 50 year influenza inactivated vaccine you can give, like in pregnancy, immunosuppressed patient, HIV, because this is a non-live vaccine, killed vaccine. So this you can provide in all these patients, asplenia, CKD patients, heart lung problem, having heart, CLD patients, having alcoholism, diabetic patient, healthcare workers, travelers. So this patient indicates all these groups. So it is no longer viewed as solely a seasonal protection, but it is a vaccine which is an essential component of chronic disease reduction and preventive adult care. So we come to the next vaccine, which is a pneumococcal conjugate vaccine, which provide protection against the pneumococcal invasive disease caused by Streptococcus pneumoniae, which has more than 100 serotypes. And recently, so we categorize two status of this vaccine, which is current status. The new vaccine, which is Prevnar 20, has been launched in August 25, and now it is available in Indian markets for adults. The strategy has shifted to single shot approach. We were previously using 2-dose schedule for pneumococcal vaccines. Now this is the vaccine which, if you give, single dose is required. Because this vaccine has broader coverage, apart from original 13 strain, it has got 7 additional aggressive strains. The single dose convenience, most adults, one single dose of PCV20 replaces whole 2 vaccine, which is PCV13 followed by PPSV23 sequence. So this vaccine is currently available for adults more than 50 years of age and those who are having adults having some high risk disease. In those patients, you can provide this vaccine. The government in pediatric age group, it has not been approved yet. We are using PCV 10, 13, and 14, but PCV 10 is only available for adults. The past status, which was the sequential era, that we were earlier using PCV 13 followed by polysaccharide pneumococcal vaccine, which was Pneumovax 23. The first PCV 13 provide memory to the immune system, but it has narrow range, while the PPSV 23 has broader coverage but lacked long-term immunity, so that required booster. So the problem was patient had to get PCV 13 first, followed by dose of PPSV after 2 to 12 months. So there was a high dropout rate, leaving them partially unprotected. So this sequence of this 2-dose schedule was indicated in more than 19 years of adults who had immunocompromised status, CSF leak, cochlear implant. So we used to give PCV13 followed by PPSV22, 23 8 weeks later. And for other chronic medical condition, the PCV13 was followed by PPSV 1 year later, and then booster of PPSV 23 5 years later. So this was the schedule, and more than 50 year, one dose of PCV13 followed by PPSV23 1 year later. So this was the indication of these two vaccines earlier, and just to mention here what are the immunocompromised conditions. So these are the immunocompromised chronic renal CKD patient, nephrotic syndrome. They are immunocompromised. Immunodeficiency, heterogenic immunosuppression, HIV patient, Hodgkin's disease, solid organ transplant, sickle cell. So all patients are immunocompromised, while the other having chronic medical condition like chronic heart disease, congestive heart failure, cardiomyopathy, patient with chronic liver disease, patient with chronic lung disease, cigarette smoking. They come in chronic medical conditions which are not immunocompromised. So what is the indication of this single dose PCV20 vaccine? So PCV20 should be offered to all adults who are 50 year plus, even if they are healthy, immunocompetent. And so the earlier the age was 65. So now the 50 year is the new 65. Now we give it at 50 year plus age, PCV20 single dose. You can offer this vaccine to adults also who have different morbidities, comorbidities, as I told you earlier in the earlier slide, and especially smokers who have high risk of pneumococcal disease. So this is the indication of Prevnar 20 vaccine. So suppose if you are vaccinating a patient who is more than 50 years of age and he has already got vaccine, maybe PCV 13 or PPSV 23. So if the patient has got no vaccines, then only single dose of PCV 20 can give. If a patient had earlier PPSV 23 only, then single dose of PCV should be given 1 year after the last PPSV 23 dose. So if the patient had received only PCV 13, again the PCV 20 should be given more than 1 year after the PCV 13. And if they had received earlier both the dose PCV 13 and PPSV 23, so single dose of PCV 20 should be offered 5 years after the last dose, that is PPSV 23. So it is just the duration that if the patient had earlier got these vaccines, so you will be offering this vaccine maybe 1 year after, or if they have already received 2 doses, then 5 years after the last dose. So again, this is the similar adult age 19 to 49 year who are having this immunocompromising condition, CSF leak, chronic medical condition. The same formula apply here. If the person has already received, then you have to give PCV 20. If any one of these two vaccine, then PCV 20 should be given more than 1 year after the last dose. If the person has got both these vaccines, then PCV 20 should be offered more than 5 years after the last dose. Now we come to the third vaccine, which is DPT, diphtheria, pertussis, tetanus, which comes as a name Tdap. We call it as a Tdap vaccine. And it is also as a TD form or Tdap vaccine. This vaccine is a toxide, tetanus toxide, diphtheria toxide, and contains acellular pertussis antigen. So it is again an inactivated vaccine. So the indication, if the person is not vaccinated, then vaccine should be given immediately in 3-dose schedule, like 0, 1, and 6. You can start with Tdap and then rest 2 of the doses you can give TD, or all 3 doses you can provide. You can vaccinate the person with Tdap, and Tdap. And any adult should receive this Tdap vaccine every 10 years as a booster dose. So if in pregnancy, the 1 dose of Tdap should be given. But if it is the first pregnancy, 2 doses should be given, first Tdap followed by another TD vaccine. In the wound management, if person has got this TD or TDF vaccine and it is clear or minor wound, then no need to give. But if it is more than 10 years, then you have to vaccinate for clean and minor wound. But for if the wounds are major and dirty, you have to vaccinate if the person was vaccinated 5 years back. So always prefer Tdap for those without previous Tdap history. So Tdap should be preferred over the TD vaccine. So this is the table showing the Indian consensus recommendation. This consensus recommendation is taken from various sources, mainly from Association Physician of India, API, and the Red Book and Purple Book of the Indian Academy of Pediatrics. And you can see the Indian consensus recommendation is that TD and Tdap should be given to almost all category of patients if they are not vaccinated. Now come to the HPV vaccine, which covers the human papilloma virus-induced cancer in patient. This HPV cause cancer of cervix in female, anal cancer, oropharyngeal cancer. So this vaccine is to prevent these cancer. And the vaccine is, again, it is a non-live vaccine. It is a recombinant protein capsid liquid vaccine. This come in two forms. One is quadrivalent and another is nanovalent vaccine. The quadrivalent vaccine contains 4 types of strains against which this provides immunity. The 16 and 18 strain causes most of the cervical cancer, while the 6 and 11 strain causes warts. So this provides protection against 4 these HPV strain. The new nanovalent HPV 9 vaccine provide another 4 strain apart from these, 5 strain apart from these 4 strains. So it is nanovalent covering 9 serotypes of the HPV. The doses are like single vaccine. It is recommended that 9 to 14 years of age in all females, the single dose is sufficient. Whether you give quadrivalent vaccine or you give the nanovalent vaccine, in girls between the age of 9 to 14 years, the single dose of HPV vaccine is sufficient and should offer this single dose to every girl who is between 9 to 14 years of age. So these are 3 different vaccines: Gardasil 4, Cervarix 4. They have 4. They are the similar strain, and Gardasil 9. Gardasil 9 can be offered to females up to 26 years of age, while the Gardasil 4 is offered females 9 to 45 years of age. Cervarix, which is quadrivalent vaccine, can be offered to both male and female from 9 to 26 years of age. So again, this is the Indian consensus recommendation that if the person or adult is immunocompromised and at risk, she should receive 3 dose schedule of the HPV vaccine. It should not be offered more than 46 years of age, because till 45 years it is recommended. If person is immunocompromised, HIV infection, anosplenia, CKD, heart and lung disease, CLD, diabetic patient, and healthcare providers, so they should get this HPV vaccine because it targets at lowering the burden of cervical, anal, oropharyngeal, and HPV-related cancer. This HPV-related cancer accounts only 7 to 8% of all the cancer. So it is a major chunk of the cancer. You should provide this vaccine to each and every girl, especially, and to boys also, under 18 year age also. The contraindication of this vaccine is should not be given in pregnancy. And if there is any severe allergic reaction to this vaccine, or there is a reaction anaphylaxis, this should be avoided. Now come to the another vaccine, which is shingles, which prevents against the herpes zoster. Herpes zoster is, if the person had suffered chicken pox or varicella in the childhood, then later he or may develop this single herpes zoster. So this vaccine is to prevent this herpes zoster. The vaccine is recombinant zoster vaccine. It is non-live vaccine. It is an activated vaccine. The dose schedule is that 2 doses, which are 2 to 6 months apart. So all immunocompetent patient more than 15 year age should get this vaccine, and the person who are at risk 18 to 50 year with different diseases at risk, they should receive also these 2 doses of shingles vaccine. Even if the person has already suffered of severity of any severity of herpes zoster, this vaccine should be offered once the patient is recovered. So the overall lifetime risk of developing this herpes zoster is around 20%, and overall lifetime risk of developing post-herpetic neuralgia is again 10 to 20%. So this vaccine has very good efficacy in 50 to 70-year-old age group. The efficacy is 91%, and in immunocompromised, the efficacy is around 70%. Against post-herpetic neuralgia, it has got very good efficacy, almost 100%, 93% in age group of 70 to 90 year, and 87% in immunocompromised patients. So this is the Indian consensus recommendation. Over 50 years of age, every patient should be offered this vaccine. Immunocompromised patient, HIV patient, patient with CKD, AR means patient who is having additional risk. Chronic liver disease patient, alcoholic patient, heart lung disease, all should be offered this the shingle vaccine. And another live vaccine which are going to discuss is chickenpox or varicella. It is a live vaccine. It is a live attenuated vaccines. The dose are 2 doses. If the patient is 13-year-old age, 8 weeks apart. Less than 13-year age in kids, we gave it 3 months apart. So 2 doses are recommended. And the person who are at risk, like patients who are asplenia, CKD patients, heart lung, CLD patient, diabetic patient, they should be offered this vaccine if they are not previously vaccinated or they don't have evidence of immunity against the chickenpox. Like you can check their IgG level. If they are less than 100 international unit per liter, that means they are non-protected. This vaccine should be offered to susceptible household contents of immunocompromised individual, and the post-exposure vaccination, if a person is exposed to any chickenpox patient, it should be vaccinated within 5 days of exposure. The contraindication of this vaccine is again if there is a severe allergy or anaphylaxis to vaccine. If the person is on aspirin therapy, then it is a precaution to give this vaccine. Now, another live vaccine, it is the MMR, the measles, mumps, rubella vaccine. It is a live attenuated vaccine, and we gave it in 2 doses, 4 weeks apart. Again, if the level of this IgG antibodies level is less than 120, that means that the person is not protected. We can offer this vaccine to those persons who are not vaccinated earlier and their antibodies level are less than 120. So post-exposure prophylaxis, if any patient is exposed to measles, this vaccine, only measles component should be offered within 3 days of exposure. The Indian consensus recommendation says it should not be given above 50 years of age, but between 18 to 49 year age, the persons who are having this asplenia, complement deficiency, or healthcare provider, they should be offered these vaccines. The contraindication of this vaccine is that moderate or severe acute illness should be precaution. You should take precaution in patients who are having moderate to severe illness with or without fever. If the patient has earlier received blood, plasma, immunoglobulin, the vaccine should be delayed or should be given after 3 months. And if the person has received this MMR vaccine, then these blood, plasma, immunoglobulin should be given at least 2 weeks interval. It should also be, there is precaution in patient with history of thrombocytopenia or thrombocytic purpura. Now come to the this meningococcal vaccine. This meningococcal vaccine comes in 2 categories, that is polysaccharide vaccine, and now it is not marketed in India, but what is available is conjugated meningococcal vaccine. There are three different meningococcal vaccine which are available. That is, one is quadrivalent, which contains ACW135 strains, and it recommended in 9 months to 55 year of age group. Another GSK is vaccine Manvio, which is recommended above 2 year to 55 year patient. Another recently launched pentavalent vaccine, which comes with the brand name of Man5. It is offered in adults more than 18 years till 85 year of age. This monovalent vaccine is licensed but not marketed, and this is provided when there is any epidemic in the community. Then this monovalent, mostly the epidemics of meningococcal is caused by A strain, so it is provided in epidemic condition. So this vaccine, the meningococcal, is not routinely given because it has got low incidence. So only special high risk situations this vaccine should be offered. So what are those conditions where the meningococcal vaccine should be offered? Like in patients who are persons or adults who are going to Hajj, or high risk travelers, microbiologists, students going to study abroad, adults living in military camps, or close contacts, they should receive a single dose of this meningococcal vaccine. And if there is ongoing risk of having meningococcal infection, then booster every 5 years. There is 2-dose schedule in adults, 8 to 12 weeks apart, who are having anatomical function dysplasia, sickle cell disease, HIV, complement deficiency, or complement inhibitor having this complement inhibitor. Then they should be given 2 doses, and then booster every 5 years if there is ongoing risk. So this is the Indian consensus recommendation. Should be given to person more than 50 years if there is additional risk. It should be given to HIV patient, a splenic complement deficiency patient, travelers, mass gathering, or these CKD if they are having additional risk. So come to the next vaccine, which is Haemophilus influenzae type B. This is a vaccine which is lyophilized killed conjugate vaccine. It is coming with pentavalent or hexavalent vaccine. The isolate vaccine is not available, but it is recommended in adults who are at risk. Means at-risk patients are like immunocompromised patient, CKD patient, heart-lung patient, CLD, diabetic patient, who have not received this Haemophilus influenzae vaccine earlier. They should be provided. They should be offered this vaccine. Comes 0.5 ml, 1 dose. But for hematopoietic stem cell transplant, bone marrow transplant recipient, this vaccine dose is 3 doses, 4 weeks apart. And this should be given after 6 to 12 months after the bone marrow transplant. Now come to the very common hepatitis A vaccine. This is a vaccine which is again inactivated vaccine, comes in 1 ml, should be given intramuscularly. It should be offered to those adults who have not earlier received this hepatitis A vaccine. So it is advised offered in 2 doses. First dose, then the second dose after 6 to 12 months of age. The person, if traveling and want both these hepatitis A and B vaccine, it comes in Twinrix bed. The 3-dose schedule should be provided. That is 0, 1, and the 3rd dose after 6 months. Another accelerated schedule for this hepatitis A vaccine, 4-dose schedule. It is 0, 7, 21, and then booster dose at 12 months of age. In case of there is hepatitis A outbreak, a single dose of this hepatitis A vaccine should be provided if the person is not vaccinated earlier. And then later the 2-dose series should be completed. If person is exposed to hepatitis A, like post-exposure prophylaxis, the person adult should be vaccinated within 2 weeks. If the person age is between 1 to 40 years, a single dose should be offered. And if the person is more than 14-year age or having chronic liver disease, immunocompromised status, Apart from single dose of hepatitis A vaccine and standard immunoglobulin with the dose of 0.1 ml per kg body weight should be offered. So these are the at-risk individual who should be offered this hepatitis A vaccine, like patient with chronic liver disease, undergoing liver transplant, HIV infection, immunocompromised conditions, homosexual, drug users, and travelers to high endemic area. If the at-risk individual is already immunized, he should receive one dose, and if it's not immunized previously, then two-dose schedule is advised. So again, this is the Indian consensus recommendation. So in HIV infection, for patient with HIV, CLD patient having alcoholism, they should be offered this vaccine if they are not immunized previously. And person with immunocompromised state, dyspnea, CKD with additional risk factors, that they should be given this vaccine. Another vaccine is hepatitis B vaccine. It is a vaccine which is recombinant DNA vaccine, not a live vaccine. Should be given intramuscularly in that way. The dose is 20 microgram per ml. So 3-dose schedule is 016. If the person is healthy, no booster dose is given. But if the person is having some disease or at risk, not immunized, then after three doses, a booster dose should be given every 5 years. If the person is at-risk individual, after giving this primary schedule of 3 doses, anti-HBs level should be assessed. And if this level are less than 10 international unit per liter, the person should again revaccinated after 3 doses. And after giving the second primary series, the person should again be assessed for anti-HBs level. If the level is again less than 10 international unit, that means the person is non-responder. So that means the vaccine is not producing that zero protection, and they are called non-responders. The person who are ongoing HBV exposure risk, they should be annually assessed, and if the vaccine should be given if their level of anti-HBC level are less than 10 international unit per liter. So this is the Indian consensus recommendation. The patient, like in pregnancy, it should be given as a immunocompromised patient, in HIV, asplenia, CKD patient, heart-lung disease patient, patient with CLD, diabetic, healthcare providers and travelers, they all should be offered hepatitis B vaccine if not vaccinated earlier. So this one slide about the hepatitis B vaccine in chronic kidney disease patient. The patient who are having chronic kidney disease in an advanced stage, more than stage 3, they should be offered this 4-dose primary series of hepatitis B vaccine. The dose is almost double of the normal vaccination dose. That there we were giving 20 microgram per ml. Here the dose is 40 microgram per ml. And there is this schedule is 4-dose primary schedule, especially in CKD patient who are planning or preparing for dialysis or undergoing dialysis. They should be offered this 4-dose schedule if not vaccinated earlier. And after vaccination, this primary series, yearly, this CKD patient should be assessed for this antibody level, that is anti-HBs antibody level. If the level are less than 10, they should be given booster dose. If the level are more than 100, then test serologically annually. So you have to keep the level of this anti-HBs antibody level more than 100 international unit per liter, and the person should be assessed annually for this anti-HBs antibody levels. Now, the Japanese encephalitis patient vaccine, which is offered in patient with who are planning to travel in a particular endemic area of Japanese encephalitis. There are 2 types of vaccine. One is inactivated varicella-derived vaccine, another live attenuated chimeric vaccine. This live attenuated chimeric vaccine is being used under universal immunization program, 19 to 18 months. In adults, we give only this inactivated varicose-derived vaccine, that is Genvac and Jeev. And this Jeev is given in 6 microgram per dose. More than 3 years of age, less than 3 years of age, we give less than 6 years of age, we give 3 microgram per dose. So 2 doses, 4 weeks apart. So this Japanese encephalitis vaccine is recommended for travelers who are staying 1 month or longer in any endemic zone. The Indian consensus recommendation says that should be given to all travelers who are going to this endemic zone. Rest of the patients who are high risk patient, based on their benefit risk evaluation, you can offer this vaccine. Now the very important vaccine, that is poliomyelitis vaccine. So we have categorized 3 type of adults. First one who are unvaccinated or partially vaccinated adults who have never received this vaccine or partially vaccinated, and they are traveling to those areas who are still endemic to poliomyelitis. So 3 doses of IPV, that is inactivated polio vaccine, should be offered. That is 0 dose, 1 dose, then 3rd dose at 6 to 12 months after the first dose, and IPV by OPV schedule, that is 1 or 2 dose of IPV followed by 2 or more dose of bivalent OPV. So any patient who is unvaccinated, partially vaccinated, and traveling to those areas should get 3 doses of IPV and should receive complete immunization. The person who is traveling and who are planning to travel, like countries like who are endemic with wild polio virus, like Afghanistan, Pakistan, or where there is a circulating vaccine-derived polio virus is there. There are still 13 countries. The list is there in WHO list, WHO website. So any patient who is traveling between India and these countries should get a single dose of IPV or OPV if not received or not vaccinated earlier 4 weeks prior to departure, and is valid for 1 year. So if that person is not vaccinated, has not got 3 doses of polio vaccine, it should be offered 1 dose, and that will be valid only for 1 year. And then after 1 year, if we again travel to these countries, then we have to again get a bivalent OPV or IPV, and there must be a certificate from district immunization officer. If the person is fully vaccinated, then he should get a single lifetime IPV booster dose, and then there is no need to revaccinate every year if the person is traveling between these countries. At high risk professionals like healthcare workers, laboratory personnel who have direct exposure risk, a single lifetime IPV booster dose. If the person is fully vaccinated earlier, still a single lifetime IPV booster dose should be offered.
Dr. Amit, sorry to interrupt. We have 8 more minutes to go. How many slides do you have left? We should leave some time for discussion also. There are some questions.
Maybe 5-6 slides, not more than 5-6 slides. Okay.
So
We'll
maybe
do it
we can
quickly.
go through them quickly so that we have
Yes.
some
It's just
questions.
5-6 slides. Okay. So this again, the recommendation I have already discussed. That this is the yellow fever vaccine. Again, vaccine which is a live attenuated vaccine. This is offered who are traveling to Africa, Central, South America, and require a valid certification. If a person is having allergy to egg, chicken, gelatin, they should be avoided this vaccine. This vaccine is contraindicated in pregnancy, lactation, person having immunosuppressions. So this is the yellow fever vaccine. The corona vaccine, we have already received this vaccine, but if there is no pandemic, no local epidemic, should not be offered, only in cases of pandemic or if there is a local epidemic. So 2 dose series is given, and so this vaccine has to be given in almost every category of patients, more than 50 year or 18 to 49 year. Different type of vaccine, Covaxin, Corbevax, Covishield are available, but this vaccine is only in pandemic or local epidemic condition only. So other vaccines are like typhoid. If the person is traveling to in endemic area during outbreak, professional food handler, the vaccine should be repeated every 2 to 3 years as a booster dose. And you already know about the rabies vaccine. Rabies vaccine pre-exposure 3 doses, post-exposure 5 doses. Cholera is not recommended routinely, and the oral vaccine 2 doses at least 2 weeks apart should be offered when there is a potential exposure to cholera patient, or there is a endemic or epidemic or outbreak. The chikungunya vaccine is not yet approved and not available. The dengue vaccine has been approved recently by DCGI and will be available by 2027. The RSV vaccine, though it is not approved in clinical use in India, but the CDC recommendation is that age 60 or older should receive this vaccine. Just a few words about the hematopoietic stem cell transplant recipient patient who have bone marrow transplant. They should be considered as a never vaccinated patient, and the vaccine should be provided to them. Again, like newborn receive the vaccine, but they should be started if it is inactivated vaccine 6 months after the bone marrow transplant, and pneumococcal, influenza, TPT, meningococcal, they should all be vaccine should be offered. If the live attenuated vaccine should be given more than 2 years after the transplant, and like MMR varicella vaccine, and they should be given only if person having no graft versus host disease and the person is off immunosuppressants more than 3 months. In solid organ transplant, the donor and recipient pre-transplant vaccination should be preferred before immunosuppression begins. Similarly, in donors who are going to donate this organ, they should have their routine immunization updated. So this is a list of vaccine. Like it is this inactivated vaccine in solid organ transplant patient. These are the live vaccine, and this should be offered. And the routine vaccination should be completed in both recipient and donors. So this is the last slide. And so once you are going for vaccinate an adult, you should checklist for these contraindication, as whether the patient is sick, having allergy to any of these. Is there was any post-vaccination reaction, any problem, long-term problem, aspirin therapy? Is there any immunosuppression? What is the family member status of immune system problem in any family member? The patient had anti-cancer drugs, rheumatoid arthritis, Crohn's disease, psoriasis. So if the patient has received these vaccine, at least there must be 3 months gap after treatment is finished, then you can vaccinate. Any seizure or neurological like tetanus toxoid vaccine should be given with precaution in patient who had this progressive neurological disease or GBS. And if person has received any blood products, there should be gap of at least 3 months. And pregnant, is the person is having pregnancy? Is there any vaccination in past 1 month? Or person has to travel internationally. So this is the checklist before you giving any vaccination in an adult. You should check these concerns. So the key message is that whenever you find any patient, every encounter counts. So you should offer patient whether it is a routine vaccination age-wise, or if the patient is having any chronic disease, accordingly you should vaccinate the patient. Should increase the awareness and address their hesitancy, because most of the adults, they think that they are complacent. They think that, okay, I am fine, I am not having any disease, I have already received vaccine in my childhood, so I don't require. But that is not the case. You should make them aware. Prevention equals longevity and an act of community protection. So if you provide protection to adults and persons in all family members, so you are protecting the child or infant also in that family. So thank you. So this was all about the adult vaccines.
Thank you, Dr. Amit, for a very good presentation. You have covered most of the vaccine and given very clear-cut recommendations. So
Thank you.
We have a few questions in the chat box. Dr. Udan. Yeah, Dr. Swati, will you please?
Yes, sir. I will read the question. Dr. Renuka has asked, if I received 2 doses of pneumococcal vaccine few years back, is it necessary to repeat a dose of PCV20?
Yes, ma'am. You can take this vaccine because it is a conjugate vaccine, and but you have to take this vaccine 5 years after the last dose. So you should take at least this PCV20 vaccine, but there should be at least 5 years gap, the last dose.
Dr. Kamlesh Kanodia has commented MPSV is available as Pneumovax 23.
Okay.
And if a person has had hepatitis A in childhood, should one still take hepatitis A vaccine?
If a person has already received a vaccine in childhood, then there is no need. Or if the person had disease during the childhood, then you have to see that whether the patient is having any chronic disease or patient is at risk. So better to evaluate his or her antibody level. If the level are below that protection level, you can offer single dose of this hepatitis A vaccine.
And, another question is, what is your take on single dose live attenuated hepatitis A vaccine?
The hepatitis A vaccine, live attenuated vaccine, can be given, uh, uh, but you have to. This vaccine is given when there is epidemic, so better to give 2-dose schedule. But you can give this hepatitis A live vaccine also. In kids, we are giving this, but you should avoid this vaccine in adults.
Okay. Thank you, Dr. Amit. It was a really informative talk. Now I invite our chairpersons to share their experience about adult vaccination in their clinical practices.
Thank you, Dr. Swati, and thanks to Dr. Amit. It is a very excellent presentation, and he covers each and every aspect of the adult vaccination. And a few points from my side, as far as webinar vaccine is concerned, this is a very routine question. Whenever patient received this is earlier, Nemo 23, or if there is a gap of 5 years, all patients or high risk patients or
Yes.
patient of over the 60 years or 65 years must receive Pavinar 20. Another thing, the question is about Shingrix. If patient already developed herpes zoster, still patient can be vaccinated with the gap of 6 months, and it is very beneficial for post-herpetic neuralgia also. These two important things I want to add. Another thing about Tdap, because there is a very not a proper awareness even among the physicians and as well as among the adult patients. So after the age of 18, we must emphasize our patient to receive Tdap also at the interval of every 10 years.
Thank you, sir.
Thank you.
Comments from Dr. B.B. Agarwal.
Thank you. I think covered most of the thing. Regarding the PCV vaccine, the new PCV21 by Merck company will be available after some time. It doesn't contain serotype 4, but overall pneumococcal strains which are prevalent in India will be covered to the extent of 77 to 85%. So it can give a better protection than PCV20 or Prevnar 20. And another comment is RSV is not available. It is also recommended in pregnancy 32 to 36 weeks.
Yes.
And then high age in CDC guidelines above 60 or 65, every individual should get. And we covered most of the things. Nothing to add from my side.
Yeah.
Dr. Vipin has raised his hand. Sir, do you want to ask a question?
Yeah, ma'am. Am I audible?
Yes,
Yeah.
sir, you're audible.
My first point is that RSV antibodies are available in 50 milligram and 100 milligram dose. And in children, we are giving it to protect below 5 kg. We are giving 50 milligram. And if a child is above 5 kg, we are giving 100 milligram. Although it is a costly vaccine, but now freely available. And pregnant mother
Cannot give in adults. So it is only for infants.
for kids only.
Yeah,
Up to
this
2
is for
years.
kids only. So the
Up to
adult vaccine is different and it is not available yet in India.
Okay, and my second point was that we could not get a India-made or India-specific adult vaccination card till date from any of the vaccine house or from any of the association, so that which we can hand over the patient and complete the vaccination. Most of the time, we just on the prescription, the vaccine sticker is pasted or vaccine is written. There is no next dose due date given. So it becomes very difficult for the adult patient to understand the whole schedule.
Yes.
I think some effort should be made on this.
Yeah. So I will request the association API that they should come with this any format or any schedule of the patient. And moreover, the government should have a policy like in kids we are using this universal immunization program. Similarly, the adults should be included in this universal immunization program. At least few vaccines should be offered to them.
Yeah. Thank you, sir. Thank you very much.
So we have come towards the end of the session. Thank you, Dr. Amit. It was really wonderful and very informative presentation. I'm sure our audience would have benefited immensely from it. Thank you to our chairpersons, Dr. Vardani sir and Dr. B.B. Agarwal sir, for sparing your valuable time and sharing important insights. And thank you, your
Thank
audience.
you, Dr. Swati. Thank you.
Thank you, sir.
everybody.
We will soon share the recording of this presentation also, so that people who have missed can also go through this
Welcome.
presentation. Thank you, everyone.
Thank you.